My topic is disorder of fluids and electrolyte and acid-base disturbances in patients with diabetes mellitus. Introduction. The prevalence of diabetes is increasing rapidly, and type 2 diabetes now accounts for 20 to 50% of cases of new onset diabetes in young people. Electrolyte disturbances are common in patients with diabetes and may be the result of an altered distribution of electrolytes related to hyperglycemia, induced osmotic fluid shifts, or a total body deficit brought about by osmotic diuresis. Complications from an organ injury and the therapies used in the management of diabetes may also contribute to electrolyte disturbances. In this review, we highlight the ways in which specific electrolytes may be influenced by dysregulation in glucose homeostasis. Sodium. Increases in plasma glucose concentration can lead to changes in plasma sodium concentration through several mechanisms. Evaluations in glucose concentration increase plasma tonicity, creating an osmotic driving force that favors the movement of water from the intracellular space to the extracellular space, thereby diluting the extracellular concentration of sodium. The plasma sodium concentration is usually low as a result of this osmotic flux of water. Increased or normal plasma sodium concentrations in the presence of hyperglycemia indicate a clinically significant deficit in total body water. Correcting the plasma sodium concentration in patients with glycemia helps to assess the magnitude of the deficit of sodium and water and provides a reasonable initial estimate of the required tonicity of replacement fluids during the course of the therapy. Correction factors predicting plasma sodium concentration after the normalization of hyperglycemia vary from a low of 1.35 millimoles per liter to as high as 4 per liter. Potassium. Hyperkalemia is frequently present on admission in patients with diabetic ketoacidosis, even though total body potassium is reduced. This condition is caused by potassium wasting, which results from the increased delivery of sodium to the distal nephron coupled with increased mineralocorticoid activity. In these circumstances, the hyperkalemia is caused by a redistribution of potassium that results from hypertonicity and insulin deficiency, not by metabolic acidosis. Potassium shifts caused by metabolic acidosis are more pronounced in hyperchloremic non-anion gap acidosis, also called mineral acidosis, than in organic acidosis, increased anion gap acidosis, which is present in diabetic ketoacidosis. Acid-base disturbances. Diabetic ketoacidosis is characterized by the accumulation of acetoacetic acid and hydroxybutyric acid. Ketoacidosis results when the rate at which hepatic ketoacidosis is generated exceeds peripheral utilization and the concentration of ketoacidosis in the blood increases. The accumulation of protons in extracellular fluid causes the decomposition of bicarbonate to carbon dioxide and water, whereas the concentration of ketoacidosis anion increases. Reductions in plasma concentrations of bicarbonate initially approximate increases in the anion gap, an important relationship discussed more fully by Campbell and Halperi. Although anion gap acidosis is the dominant disturbance in diabetic ketoacidosis, hyperchloremic normal gap acidosis can also be resolved depending on the stage of the disease process. Resuscitation with balanced electrolyte solution can mitigate the severity of normal gap acidosis during the recovery phase. Hyperkalemic renal tubular acidosis. Hyperkalemic renal tubular acidosis, type 4 renal tubular acidosis, is a common condition among patients with diabetes and over nephropathy. The disease is characterized by disturbances in nephron function, which lead to impaired renal excretion of hydrogen and potassium and result in hyperkalemia and hyperchloremic normal gap acidosis. Type 4 renal tubular acidosis may be present even in patients with mild to moderate diabetic nephropathy. And the magnitude of the hyperkalemia and acidosis can be disproportionately severe rela- relative to the observed reductions in the GFR. A deficiency in circulating levels of aldosterone or disease affecting the collecting duct may lead to type 4 renal tubular acidosis, which results in the defect in the distal secretion of hydrogen ions. Divalent cations and phosphorus. Disturbances in divalent cation and phosphorus homeostasis are related to hyperglycemia and are thus common in patients with diabetes. Epidemiologic studies suggest that low magnesium intake is associated with an increased risk of diabetes, whereas a higher magnesium intake is associated with a decreased risk of diabetes. In addition, hypomagnesemia may impair glucose disposal and contribute to cardiovascular disease, retinopathy, and nephropathy. The incidence of hypomagnesemia in patients with type 2 diabetes ranges widely from 13.5 to 47.7%. Causes include poor oral intake and the chronic diarrhea associated with autonomic neuropathy. Conclusion: the dysregulation of glucose homeostasis leads to many direct and indirect effects on electrolyte and acid-base balance. Since the high prevalence of diabetes ensures the clinicians in virtually every medical specialty will interact with these patients, familiarity with related electrolyte abnormalities is important.